Hello, my name is Diana Dean, and today I will be talking to you about case 5.1. Should doctors talk to relatives without a competent patient's consent? We are all aware that when an incompetent patient, such as one who is unconscious or minor, a surrogate decision maker is established to be informed and provide permission or dismissal of medical treatment. However, what happens when doctors talk to relatives without a competent patient's consent? The General Medical Council guidelines do not discuss sharing information with relatives of competent patients. However, they do state that the protection of confidence is important and that consent for disclosure outside the healthcare team should be sought, which implies that consent should always be sought for a patient before talking to relatives when the patient is present. In case 5.1, Oliver, a newly established doctor, is completing his rounds as a doctor and comes to the door of an elderly female patient who has been diagnosed with myocardial infarction, or MI for short. He gives the family of the patient basic information without sharing what exactly her diagnosis is. However, sometimes families ask, just what is Granny's prognosis? This causes two moral dilemmas. First, that the patient's autonomy may be weakened when left out of a conversation. And second, that the information may be shared with relatives that the patient does not wish to be shared. Given the dilemmas, Oliver chooses to ask clinicians in his ward their view on the issue, and they stated it was important to involve relatives and share information with them, and that consent for disclosure should first be sought. Oliver chose to share the diagnosis with the relatives, not taking consideration of the rare significant distress caused by sharing information the patient did not wish to be shared. He even stated he favored the other approach learned in the ward, not because it is theoretically better, but because the practice works well. I do not agree with this decision because professionals are expected to put ethical values first, not because they are easy, but because it is the right thing to do. In the example, it did not even say that he asked Granny's permission before sharing the diagnosis, even though the clinicians told him to. Based on Granny's diagnosis of chest pain, it was reasonable to assume that she was a competent patient because she was still conscious, able to talk, an adult, and her thinking was not inhibited by her diagnosis. Now, if any of the previously listed symptoms had been true, then it would have been fair to discuss the matter with her family without her permission, since she would have been considered incompetent. In support of my decision to put ethical values first and not tell the family Granny's prognosis without her permission, I present Cecilia Bach's first premise: the individual autonomy over personal info. We must remember that each person is entitled to keep secrets, and we usually do not have grounds to share their secrets for them. In Bach's essay, The Limits of Confidentiality, a story about an engineer who is diagnosed with polycystic kidney disease decides that he and his wife will not tell their two children about the disease, even though it is genetic, and once diagnosed, the patient usually only has 10 years left to live. They chose not to tell their children because it was not guaranteed that they had inherited the disease from their father and did not want to worry them unnecessarily or cause their social life to be affected. None of the medical professionals shared the parents' secret to the children because it was their duty to respect the parents' wishes, and there was no harm caused to the children by withholding the information from them. How can a doctor be sure Granny would be comfortable with him sharing the information if he never asks? Cecilia Bach's fourth and final premise should also be taken into consideration. Bach's fourth premise assigns weight beyond ordinary loyalty to professional confidentiality because of its utility to person and to society. Most professionals take classes over ethics, which include a professional's confidentiality of clients. Bach points out in her essay that confidentiality allows patients to seek help they might otherwise fear to ask for. Doctors are no exemption. The case even states that the doctor tried to reconcile the approach taught in the classrooms with what was taught in the ward, but in the end chose to favor the wards just because it was easier and worked better. Also in support of my decision that the doctor must have a patient's permission before sharing their diagnosis, I present Kenneth Kitness's essay, A Defense of Unqualified Medical Confidentiality, in support of my decision. In the case, a physician is faced with an impossible decision: to break his client's trust and tell his ex-wife that her ex-husband has AIDS, or to not tell her and uphold the confidentiality of his client's diagnosis. Well, in the end, he decides to tell the man's ex-wife he chose to do so not only because her life was at risk, but because he knew that she likely did not have AIDS because she was his former patient. The risk was real since her ex-husband informed him that they were trying to work things out again. He gave the ex-husband a chance to tell his ex-wife on his own, but he refused to do so, and he had never promised the ex-husband that he would not tell the ex-wife. In conclusion, the doctor mentioned in case 5.1 should not have chosen to tell Granny's family of her diagnosis without her approval. As Bach stated, we must respect individuals' autonomy by allowing them to choose who knows of their condition, and no one's life was hanging in the balance depending upon the knowledge of Granny's diagnosis, giving cause for the doctor to break the confidentiality. Thank you for taking the time to watch my presentation of case 5.1 and have a